Hey guys, so we'll discuss some questions. These are actually not questions, these are those hot topics or burning topics which tend to reoccur again and again in exam. So like some of these questions, they also came in NEET PG paper. So similar questions I have seen in last year in FMGE exam. So we'll try to go with these questions and some topic considering past 2-3 years of your FMGE exam. So if I start with the first one, a patient with acute onset stroke developed, I can say developed wild flinging proximal ballistic movement. So just try to understand this. You can notice the patient is having wild flinging proximal ballistic movement. This is of limb on one side. What is the likely site of lesion? So just try to understand this. It's basically a question from your movement problem. So just let me try to tell you something. There are certain involuntary movement. One is called your semi-purposeful involuntary movement. We call this chorea. So chorea you will see whenever there is damage to caudate nucleus. So chorea, whenever you see there will be damage to caudate nucleus. Then I can say next is your athetosis. Athetosis. This is also a type of involuntary movement. You will see whenever there is damage to your globus pallidus and putamen. Then sometime you will see strong jerky movement, a movement with a force, jerky movement. This jerky movement, what we call this hemibalismus. This is a strong jerky movement. We call this hemibalismus. And hemibalismus you will see whenever there is a lesion in subthalamic nuclei. So these are three lesions that we should remember. So how to remember this? Look at the screen. C for chorea, C for caudate nucleus. Okay, if I write gap means G for globus pallidus, P for putamen, and between these globus pallidus and putamen, what we see? We see an A, that A is athetosis. Simple. Balismus, thalamus. So balismus, thalamus. So now let us see what we can see. You can see a wild flinging proximal ballistic movement. It means it's a strong jerky movement, that is they are asking about hemibalismus. So when you see hemibalismus, whenever there is lesion where? In your subthalamic nuclei. So these are three things that they keep on asking again and again. So what is the site of lesion? Simple. What is the site of lesion? So this is important that they ask in exam. So this you should remember. Okay, if I say next thing is, next MCQ, a patient with history of fatigue. So let me say there is history of fatigue. Blood workup shows hemoglobin 10, MCV 60. So you can see hemoglobin is 10, MCV 16 means it's a microcytic anemia. So let me write the microcytic hypochromic anemia differential. I told you that is Sheetal. Sheetal means your sideroblastic, iron deficiency, thalassemia, anemia of chronic disease and lead poisoning. Okay, so if I say S for sideroblastic anemia, which is not that common, lead poisoning, not that common. Now we are left with three things: iron deficiency, thalassemia, anemia of chronic disease. So remember, anemia of chronic disease can be microcytic, it can be normocytic. Simple. So let us see the question more. RBC count is given 5.2, MCH is given, MCHC is given. So generally in MCQs you will see RBC count usually they don't give. They give values like this. They give value of hemoglobin, MCV, MCH. RBC count here they have given you for a reason, because they want you to calculate Menzer index. If you remember our class notes, I told you this how we calculate Menzer index. So remember, this is your Menzer index we should calculate whenever we see microcytic hypochromic anemia. So how we calculate? We will calculate by MCV divided by RBC count. So MCV, I can say MCV, you can see here 60. RBC count is 5.2. So let me say it is 5. So this will come around 11.8 or 11.9. So let me write this, it is coming 12. If you divide this, it will come approximately 12. So 12 means it is less than 13. And what I told you, if it is less than 13 means low. Low means low values are seen in thalassemia. And if you see, if values are more than 13, where we see this? We see this in iron deficiency anemia. So with this Menzer index, we can differentiate thalassemia from iron deficiency anemia. Now let us see here, you know the diagnosis is clear, thalassemia. So thalassemia, how you will make a diagnosis? You can do high performance liquid chromatography, we call this HPLC. HPLC is not given in the option, so let's see the options what they have given. Serum ferritin we will do when we think iron deficiency. Serum folate, in folic acid deficiency you will see macrocytic anemia. So MCV value will be more than 100. Folate is ruled out. Homocysteine is associated with folate and B12 ruled out. What is this HbA2, HbF level? That is what we call, we are estimating levels of different type of hemoglobin. That is what we call electrophoresis. So this is your electrophoresis. So this is the case of, so first try to make a diagnosis. So diagnosis is thalassemia, and thalassemia, what we do? Hemoglobin electrophoresis. Simple question. Am I clear? Okay, if I say coming to the next one. See this question like similar question they have asked numerous time in exam. So if I say first thing is, you will notice like patient complaint of fever. There is dyspnea, dry cough. There is dyspnea, dry cough, night sweat. Fever, dyspnea, dry cough, night sweat since 3 months. So initially by looking at this, what we think it could be tuberculosis, but we should not be in a hurry. Just read the question carefully. On examination, there is muscle weakness on both sides of face. Red eye. X-ray shows bilateral hilar lymphadenopathy. What is the mostly likely diagnosis? So let us see one by one. If you see these symptoms, fever, night sweat, weight loss, these symptoms you can see in lymphomas as well. I told you in hematology lecture, so I can say in hematology, in lymphomas, we call them B symptoms, right? So lymphomas you can have, but in lymphomas, you will not see hilar lymphadenopathy, usually is not seen, right? So let me say one by one. So lymphoma, there is nothing given like lymphoma, no weight loss, right? There is nothing like blast cells, immature cells. Then I can say hypersensitive pneumonitis. So there is no prior history. So like it is something that we see in farmers due to some exposure. So not that kind of history is given. Dry cough is something that is seen, that is not seen in tuberculosis. In tuberculosis, mostly what we see cough with sputum, right? Then we see the biggest hint they have given is muscle weakness on both sides of face. Means patient is having facial nerve involvement. Red eyes means there is conjunctivitis or uveitis. So it means they are giving you all MCQs. It is a granulomatous inflammation. It looks like TB, but it is not TB. It is your sarcoidosis. Why not TB? Because in TB patient, usually they will not have facial weakness, right? So answer is sarcoidosis because they are giving you fever, you can see, dyspnea, you can see, dry cough, you can see, night sweat, you can see muscle weakness on face, like sometimes sarcoidosis associated with syndrome like Heat-Fort syndrome, Lofgren syndrome. There is uveitis, and you can see bilateral hilar lymphadenopathy, right? Sometimes you will see 1, 2, 3 sign or Garland sign. So these are all things about sarcoidosis you should remember. Sarcoidosis, remember few important thing. If I said is more in female, you will see there will be hyperkalemia in sarcoidosis. You will see there will be increase in level of angiotensin converting enzyme, and you will see in X-ray 1, 2, 3 sign or Garland sign, that is a right and left hilar and right paratracheal lymph node will involve. And now you will manage the treatment is steroid, right? Okay, coming to next question. It is like similar question I have seen a lot of time in exam. Patient complaint of bradykinesia rigidity. So usually what they ask, a tremor, rigidity, bradykinesia. So just I'm writing this once again. So you know the diagnosis. I'm expecting you know the diagnosis: tremor, rigidity, bradykinesia. So this is like a triad. This triad, what we see, where we see in Parkinson disease, right? Then I can say, if I say the fourth feature that you should remember in Parkinson, that will be there will be tremor, rigidity, bradykinesia. These are 3 common features. If I say before these feature, you will see earliest feature that sometimes they ask is anosmia. So this is something, anosmia is an earliest finding, but it is oftenly misdiagnosed. So you cannot make a diagnosis with anosmia because many patients, they will ignore this finding. So you will see tremors, rigidity, bradykinesia, these are classical symptoms, classical triad, right? And fourth thing, if you will see, the patient can have postural instability. And you can see some other things like there will be mask-like face, there will be decreased blinking, fascinating gait, there will be stooped posture. So these are other features you will see. Now question is treatment to be initiated. So you know the treatment should be initiated will be your levodopa. So if I say how you manage, the question they are asking, so treatment should be levodopa. Levodopa, whenever you give to patient, this is degraded by an enzyme called dopa decarboxylase. So levodopa, before it reach your brain, this is destroyed by this enzyme. So we should inhibit that enzyme which is degrading levodopa. So that is called your carbidopa. So what is carbidopa? Carbidopa is your dopa decarboxylase inhibitor. So I can say what you are using carbidopa. So this is the treatment of choice. But when it is not controlled, now you can see nothing is there. Option in option is missing. So let me see. Clozapine is atypical antipsychotic. Antipsychotic drugs, in fact, they can cause extra pyramidal side effect. Clozapine causes minimal. Usually it is seen with typical antipsychotic, but it can also cause promethazine. There is no use here. Donepezil is used in Alzheimer. So we have selegiline. So remember, selegiline, rasagiline, asafinamide. These are your MAO inhibitor, right? So we have MAO inhibitor, COMT inhibitor. COMT inhibitor like anti-capon, tolcapon. So these are used in Parkinson disease. So basically they have asked the question, so I can use levodopa plus carbidopa. This is first option which I am having in a patient of Parkinson. Second is I can use MAO inhibitor like selegiline, rasagiline, asafinamide. Then what we can use COMT inhibitor, catechol-O-methyl transferase inhibitor. That is your I can say anti-capon, tolcapon. So this minus sign is inhibition, MAO inhibitor, COMT inhibitor. Then I can use some drugs which are dopa agonist. Dopa agonist like your pramipexole, ropinirole, roticotin. In fact, one more I can say bromocriptine. So bromocriptine, remember it is recently we are using this to treat Parkinson as well as it's also approved for diabetes now. Bromocriptine, Parkinson as well as diabetes. Then I can also use amantadine here. Then I can say if everything is failed. So if everything fail, in that case what we use a surgery. That surgery is called as deep brain stimulation or DBS. So this is deep brain stimulation. When we do in refractory cases. So this is a case of Parkinson disease. So answer will be selegiline. Okay, then we have a question on hepatitis. A patient presenting with anorexia, jaundice, right upper quadrant pain. Investigation shows HBs antigen positive. Okay, so let us see this. Anti-HBs antigen negative. IgM is positive. So I am highlighting those things which are positive. So remember, for this questions, like if you see my videos, you don't have to even see the options. So I can say I told you SCECES, SCECES, right? SCECES. So what is the meaning of this SCECES? The meaning of this word SCECES is S is your hepatitis B surface antigen. Okay, hepatitis B surface antigen. This will be your hepatitis B core antigen. Hepatitis B envelope antigen. So first three is a sequence of antigen. Then we have next three. So this is your antibody sequence. So anti-HBC antibody, anti-HBE antibody, anti-HBS antibody. Okay guys, so just try to understand this. If I can say, when you see SCECES means first three will be sequence of antigen. So whenever you see this antigen is positive, surface antigen is positive, it means there is entry of virus. There is entry of virus. If you see core antigen means it is not detected in laboratories. This is not detected, so not asked in MCQs. Simple. HBE antigen is positive. If this is positive, it means virus which entered your body. Now this virus is replicating. It means it is dividing. So this means virus is replicating. Dividing means this is turning into infective disease. It is contagious. It is infective now. If you see antibody development of antibody, so I can see antibody, either it could be IgM or it could be IgG. So what they write like this, it could be IgM anti-HBC antibody, or they can give you IgG anti-HBC antibody. So if IgM is positive, so you know from your immunology pathology knowledge, like IgM means it's an acute infection. If I say IgM means this will be acute infection, acute or primary manifestation, and I can say IgG means this is telling you about chronic infection. Now if antibodies, so HBE antigen was telling like virus is now dividing. If you develop antibody against that antigen, it means that virus which was dividing, if this is positive, it means it is no longer dividing. No longer dividing means it is now no longer infective. It means it is end of infectivity period. This virus is no longer infective. And ultimately, if you develop antibodies against the surface antigen from where we started, it means this is now cured. Clear? So let's try to understand this question. It's very simple. If you see now what things are positive here, so that you should focus what things are positive. So first thing is positive is your surface antigen. It means there is entry of virus. Simple. Second thing that is positive is IgM. It means it is acute. Hepatitis C is negative. So this, remember, these are markers for hepatitis B. So if I say what will be your diagnosis, it is acute and it is hepatitis. So this will be your acute hepatitis B. Okay, in the same question, if I add HBe antigen positive, then diagnosis will become acute infective hepatitis B. Right? Acute infective hepatitis B. Okay, in the same question, if I give you, instead of IgM, I write here IgG, then it will become chronic hepatitis B. Simple. So this is like one of the easy question. Remember this, SCE, first three is SCE, then we have CES. It's not like SCE and SCE, it is SCE, CES. So this is how to remember a question on this easy topic. Okay, patient present with acute headache with nausea, photophobia, phonophobia. So what is the diagnosis? Simple. There is headache. So patient is having headache, and this headache, I can say it is moderate to severe. Either moderate or severe. It is not mild. This headache is unilateral, right? So patient is having headache that is moderate to severe. It is a unilateral headache, means it's one side of your head. So sometimes we use the word hemicrania. Then understand this, the patient is having headache. This headache, I can say the duration will be for 4 to 72 hours. 4 hours to 72 hours. So there is moderate to severe headache. It is unilateral headache. The duration is 4 to 72 hours. Then I can say this headache is associated with nausea, vomiting. Or this headache is associated with photophobia, phonophobia. Right? And this headache, okay, just let me change the number, 4, 5, 6. This headache is aggravated with movement. Aggravate with movement. So understand this. When they mention these things, photophobia, phonophobia, then you understood they are asking about migraine. So remember, any 2, 1, 1. So what we need to make a diagnosis, we need any 2 features. From first 4, any 1, 2, 1, 1. So you can see it's acute headache with nausea is there, photophobia is there, phonophobia is also there. So this is a diagnosis of headache. So they are asking acute migraine. So how you will manage acute migraine? The answer will be sumatriptan. Simple. Fluoronazine, topiramate, propranolol, verapamil. Do we use in migraine? Answer is yes. But we use these drugs in case of prophylaxis of migraine. So remember in migraine what we use? In acute attack we use sumatriptan. In case of prophylaxis, what we use? Fluoronazine, topiramate, verapamil, propranolol. These kind of drugs we use in prophylaxis. Okay, then what they can ask you like what else we can use in migraine. So in migraine we have a few more treatment options, like there's a toxin that we use, we call this ona-botulinum toxin. This toxin we can use in migraine. Then some new drugs what we use in migraine, these are your GPANT. The GPANTs will act on your calcitonin gene related peptide CGRP. So we call them ubrogepant, rimegepant. The drugs are rimegepant, ubrogepant. Right. Then we have some monoclonal antibodies like arnumumab. These are also used in migraine. So remember, this is how we make a diagnosis. Okay, so I can say normal pH. Let me tell you before going to this question. If I say pH, normal pH is 7.35 to 7.45. And if I say normal PaCO2 level, just let me take this 0.35 and 0.45 down. That's it. So I'm writing this 35 to 45. Simple. 35 to 45. So these are the normal values that you need to see. Then remember a thumb rule. If pH and PCO2, they move in same direction. Same direction means either both are increasing or both are decreasing. Same means SAME. SAME means this is metabolic. Then disorder is metabolic. After that you can see the pH. If pH is less, we call this acidosis. If pH is more, we call this alkalosis. Then I understand this if I say pH and PCO2. If they move in opposite direction, so let me write opposite, or I can say reverse. If they move in reverse direction, so R for reverse, R for respiratory, then disorder is respiratory. So pH and PCO2, they move in same direction, disorder is Metabolic, opposite direction disorder is respiratory. So answer for this question, if you can see. So let me show you the question. So you can see pH is 7.2. So just I'm writing here 7.2 and PaCO2 is 80. This is your 80. So if you see this, pH is decreased, and PaCO2 is increased. So you can see the direction. If you see pH is decreased, PaCO2 is increased. So direction is opposite. Opposite means reverse. R for reverse, R for reverse, R for respiratory. So this is respiratory and pH is reduced means acidosis. So diagnosis will be respiratory acidosis. Respiratory acidosis. Simple. Okay guys, so let's see a few more questions. Which of the following is least likely cause of pleural disease? Pleural effusion means they are asking which disease is least likely to cause pleural effusion or pleurisy. So just try to see, look at this question. So like what I told you, like there are certain drugs that can cause pleural effusion. So one of them is dantrolene. So dantrolene that we use to treat malignant hyperthermia that can cause pleural effusion. Then I have also discussed bromocriptine with you, and we have also discussed methotrexate. So these are a few drugs which can cause. In fact, nitrofurantoin can also cause. So this question came recently in NEET PG exam. So what I want to just convey an information here, like I have discussed this in the class lecture as well. So you can see this is the screenshot which I am having. Dantrolene, bromocriptine, methotrexate. These are the drugs which are causing pleural effusion. So just try to understand this. If I say in this question, metformin is very common. See, just try to understand this. This is a rare drug that we use. Bromocriptine we also use very rarely to treat prolactinomas. Metformin is very commonly used drug. Right? If it could be causing pleural disease, then we could not have used this that common. So it is like I can say most common use anti-diabetic drug is your metformin. So that is your answer. Least likely cause metformin. Simple. So by just logic also, many students mark this question correct. So you should also know in some paper we need to use your knowledge or logic. 7-year-old child, a palpable purpura arthralgia. So this is a topic which I am seeing from past 2 years. The topic, same topic, means that is a disease is coming again and again in NEET PG as well as FMGE exam. There is palpable purpura arthralgia, pain in abdomen, melena. So it's a child. So you can see this is palpable purpura means it's a vasculitis. It's a small vessel vasculitis. We call this HSP, Henoch-Schonlein purpura. Right. So like they have also asked you an image-based question. So you will see a rash where in the buttocks and the thighs because of involvement of GI vessels. Patient can have melena. There can be abdominal pain. So if I say this type of disease HSP, how you will manage? So remember, it is in most of the cases this is self-limiting. Self-limiting means no treatment is needed. Few cases, like I can say, like 2 to 10% people they may have some severe manifestation of disease, so there can be renal involvement. In that case, what we give low dose steroid. So very rarely we need other drugs. So generally it is controlled with low dose steroid. So remember, azathioprine, methotrexate, these are cyclophosphamide, these are steroid sparing agent. Usually they are not needed. So they are asking you which you will use. So usually it is self-limiting, but self-limiting is not given the option. So what we will give, we will use low dose steroid. In last attempt, they have also asked you this HSP is associated with which condition? It is associated with IgA nephropathy. IgA nephropathy. This is a condition that you'll see it is associated with Henoch-Schonlein purpura. Okay, 7-year-old boy with an inappropriate weight for age, bloating steatorrhea, vitamin K deficiency, HLA DQ2 positive, biopsy showing villus atrophy, crypt hyperplasia. So many of you already made the diagnosis. Just understand it's a malabsorption syndrome. So malabsorption syndrome, understand. In malabsorption syndrome, what we have less absorption. So there is a gut rule. If not something is not absorbed, so this will be, if something is not absorbed, why we eat food? To get some nutrients. So that nutrient you will not get. When you will not get that nutrient, you will get deficiency of. So in malabsorption syndrome, understand this, the patient can develop diarrhea because food is not getting absorbed. Sometimes there can be vomiting, and many patient will complain of fatty stool. This fatty stool is called steatorrhea. When your stool fat percent is more than 7, that is stool fat is more. Or what else I can say, in malabsorption syndrome, you will see when food is not giving you nutrition, so there will be nutritional deficiency. There will be multiple vitamin deficiency. Not only vitamin K, there will be multiple nutrition deficiency. So there will be nutritional deficiency, like there will be vitamin deficiency, there will be iron deficiency if it's affecting your duodenum, there will be folic acid deficiency if it's affecting your jejunum. So these are some common feature of malabsorption syndrome. One more hint is here, that is HLA. So that is, you can see HLA DQ2. This is classically associated with celiac sprue. If I say the more classical hint that they are giving you histopathological finding. So normally what we see, we can have, these are called villi, and we have depressed part called crypt. Villi, crypt, villi, crypt. So this is like we call this villi, and this is your crypt. So normally you will see in intestine we have villi and crypts. What happen in malabsorption syndrome? You will see there will be atrophy of villi. So you can see the villi height is reduced. So what we call this villus atrophy. Villus atrophy means villi height. Just calculate the height of villi. See this height and compare this height with this height. So villi कैसे हो गई, छोटे हो गए, villi height is reduced. So this villus atrophy you can see in any malabsorption. Like you can see this in tropical sprue, you can see this in celiac sprue, you can see this in giardiasis, you can see this in lactose intolerance sometime. But understand this, you will see villus atrophy and crypt hyperplasia. You can see hyperplasia means increase in number. So see villi, crypt, villi, crypt, villi, crypt. So you can see crypt number is increased. So here you will see there is villi atrophy, and along with this you will see crypt hyperplasia. Hyperplasia means increase in number. So when you see these two things together, this is a classical finding that we see in celiac sprue. So in celiac sprue, this is the classical findings. What else you should remember in celiac sprue? Remember few important things. There is hypersensitivity to bro, barley, rye, oat, wheat. R is not rice, it is rye. There is HLA-DQ2. In celiac sprue, you will see these cereals are called gluten cereals. So sometimes we call this gluten sensitive enteropathy. Gluten sensitive enteropathy, or I can say gliadin sensitive. Gluten or gliadin. Then remember in celiac sprue, you will see villus atrophy. Plus along with this you will see crypt hyperplasia. So celiac sprue is one of the important topics that they ask again and again. In celiac sprue, what else you should know? The treatment is avoidance. Avoid bro. You can give maize, you can give rice, but avoid this barley, rye, wheat and oat. So avoid these cereals. And this is associated with a skin condition, and that skin condition is called as dermatitis herpetiformis. Dermatitis herpetiformis. And if I say in celiac sprue, you can sometimes see some antibodies, like you can see anti-endomysial, and you can see anti-TTG, anti-tissue transglutaminase. So these are all possible MCQs. So if I say treatment is avoidance, suppose you are having a patient, I once had a patient like this. When you totally avoid celiac, the gluten containing cereals, still there is no relief, right? So just I am writing this, there is no relief from dietary gluten restrictions. So most of the patient, they will have control, good control. But what is the human nature? We are Indians, we like tasty food and we eat glutens. So sometimes what happens, this person is eating chips, wheat chapati, they will get the symptom. So here let's see the question. The treatment will be gluten restricted diet. But if it is not controlling after this, then that celiac is called refractory celiac. That celiac is called refractory celiac disease. And in refractory celiac, we need to restrict soya, we need to restrict other cereals, and we should give steroid, right? So that is what we call refractory celiac. So we should also restrict soya items, right? So answer is your celiac sprue or gluten restricted diet. So let me say 26-year-old female. Let me see the next question. 26-year young female, history of arthralgia, joint pain. So there is joint pain. There are oral ulcers, skin rash, BP is high, microscopic is having 3 plus RBC means hematuria. So basically you are getting an idea. There is hematuria means it's some nephritic syndrome. It's nephritic type of glomerulonephritis. So like in nephritic what we see pari. Pari means PSGN. You will see Alport syndrome. You will see anti-GBM. Anti-GBM means good posture syndrome. Right? You can see RPGN, rapid progressive glomerulonephritis. You can see IgA nephropathy. So these are diseases where you will see pure nephritic syndrome. Pure nephritic syndrome. And if I say there are two diseases like PSGN, like your lupus nephritis, or we call SLE nephritis, and MPGN. Lupus nephritis and MPGN, they will have mixed feature. Mixed feature means they will have feature of both nephrotic and nephritic syndrome. Okay, so let's see this question one by one because they are asking you to make a diagnosis. So see, good posture syndrome is also called as anti-GBM, anti-glomerular basement membrane. So to make a diagnosis of good posture syndrome, there should be some pulmonary manifestation. There is no pulmonary manifestation in the MCQ. Alport syndrome will have a classical triad, that is can't see. So there will be anterior anticonus, there will be can't hear, there will be SNHL and can't pee. That is, there will be some kidney manifestation. So SNHL, you will see glomerulonephritis, nephritic type of glomerulonephritis, and you will see anterior anticonus. So Alport is not the answer. There is no eye and ear finding. PSGN patient, PSGN can be the answer. But remember, PSGN, they will have history of exposure to sore throat or skin infection. There is no as such skin infection. Skin rash is given, okay. But there is no skin infection. There is no erysipelas or psoriasis-like feature. RPGN is a complicated, it's a late stage, right? MPGN again, there will be some history of some drug exposure or there will be some infection. But what MCQ is giving you hint? Is giving you hint of arthralgia, joint pain, oral ulcers, skin rash, young female. So these hints are sufficient to make a diagnosis of SLE. And nephritis that we see in SLE is lupus nephritis. Simple. Nephritis that we see in SLE is your lupus nephritis. So we have different types. The most common type is, we call this lupus nephritis. The most common type is type 4. And this type 4 is called as DPGN, diffuse proliferative glomerulonephritis. Simple. Okay, so the next question, a patient consume 8 tablets of Digoxin. Okay, so first just try to understand this. Digoxin is a drug that we use in treatment of atrial fibrillation with heart failure. So some of the time what happens, there is a toxicity of this drug Digoxin. So if there is, with this toxicity, if there is tachycardia, increase heart rate with arrhythmia. So sometime it can cause tachycardia with arrhythmia, like it can cause your Gemini rhythm, it can cause bi-Gemini rhythm, tri-Gemini rhythm, it can cause a PAT, it can cause different type of, sometimes it can cause torsades as well. So if there is heart rate increase and some type of arrhythmia, then we need to give the safest antiarrhythmic drug, that is lidocaine. Here there is a twist in the question. In other cases of digoxin poisoning, what we give? In other cases, what we give? We give digibind antibody fragment, digibind. So see, the MCQ digoxin is there, but heart rate is 56, ECG showing 3rd degree AV block. So there's no tachyarrhythmia yet. Patient is having block after digoxin. So if you give drugs that will reduce the heart rate, you are going to kill the patient. Lidocaine will decrease the heart rate, so you should not give. If I say cardioversion, you should not do, because it is like patient is having AV block. In AV block, 3rd degree AV block, that is an indication to apply a permanent pacemaker. Propranolol will decrease, so answer will be digibind. Simple. So here your goal is to increase the heart rate. Following decrease serum potassium by shifting into cell. So like they're asking you the management of hyperkalemia. So if I say whenever there is more potassium in your body, you will see there will be ECG changes. So like I can say 3.5 to 5.5, that is a normal value of potassium that we see. If you see some changes in potassium, so how you will manage? Hyperkalemia can produce TALT and a T-Wase. So the treatment of hyperkalemia I can divide into 3 headings or into 3 divisions. So first is I can give something that should antagonize potassium. So I can give something to antagonize. So first thing which I can give is something that antagonize potassium. Okay, potassium is more where in the blood. From where it came from cells. So potassium came from cells into blood. Now I should send this back into cells. So that is what we call this redistribution. So there are certain drugs that will send potassium from blood back to cells. Suppose you tried this type of drug also, there is no relief, then I will use a third drug that will remove the potassium. So I can use something that is causing removal of potassium. Simple. Now understand this. Antagonist of potassium, what we use, we can use calcium gluconate. So you can use calcium gluconate. If it is not available, we can also go for calcium chloride. Don't mark the answer calcium carbonate. Calcium carbonate is your normal calcium tablet that is given in chronic hypocalcemia. Calcium gluconate or calcium chloride. If I ask you the DOC for hyperkalemia will be calcium gluconate. If I say redistribution means you are giving something that will send potassium back from blood back to cells. So that will be your redistribution. So for this what we can give? For this we can give insulin. For redistribution I can give insulin and I can give a beta agonist, like I can give albuterol, salbutamol. So you can give them by a nebulizer or sometimes we can also use them IV. Albuterol, salbutamol. Suppose if you tried all these two, there is no improvement, then we can give some diuretics. So you can use some diuretics, they will remove the potassium, right? So you can use which diuretics? Okay, you can use any diuretic. Which you should not use is potassium sparing. यहाँ पर स्पाइनोलैक्टोन नहीं देना है, स्पाइनोलैक्टोन एमिलोराइड एप्लेरिनोन नहीं देना है, because here we need to use normal diuretics like your furosemide. So generally what we use Lasix or furosemide. Okay, you try diuretics, there is no improvement, then we can give something that can bind potassium. We call them K binders. K binders. That K binder is what we can use. We can use sodium polystyrene sulfonate, SPS. We can use sodium zirconate. Sodium zirconate. So we can use sodium polystyrene sulfonate, sodium zirconate. We can use pyromer. Right. Okay, so like some of you are confusing between sevelamer and pyromer. Sevelamer is your phosphate binder. So we can use pyromer, sodium polystyrene sulfonate. We can use sodium zirconate. Suppose ये भी fail हो गया, no improvement, still potassium is very high, patient can have arrhythmia anytime. So last option what I am having is dialysis. So these are the treatment option available for hyperkalemia. यहाँ से क्वेश्चन पेपर में आएगा definitely. This is a very very important topic, hyperkalemia. Clear? So what we will give? We will give insulin. Simple. Okay. Chronic liver disease, developed ascites, diffuse pain in abdomen. Ascitic tap is showing 600 PMN, 600 polymorpho-neutrophils. If you see more than 250, that's already you are making a diagnosis. Similar question came in last attempt in FMGE exam. This time this question came in 8PG exam. You can see this is like in abdomen you are having fluid and that fluid is getting infected because there is neutrophils numbers are more. So anytime patient can develop encephalopathy, anytime patient can develop more complication. This is your SBP, spontaneous bacterial peritonitis. It is spontaneous bacterial peritonitis. So remember, for SBP, how you will treat? You need to give cefotaxime. So we give IV cefotaxime 2 gram PD. That is the DOC for treatment. So if I say patient had SBP, spontaneous bacterial peritonitis, now somehow you manage the patient successfully, you are discharging the patient, he should not have this again. For prophylaxis, so I am writing PX for prophylaxis. What we give norfloxacin. So now this is the expected question they can ask you. Cefotaxime, drug of choice, and drug of choice for prophylaxis will be norfloxacin. Okay, patient presented with features of meningitis. CSF tap is showing increased protein, mild decrease in glucose, and image is given. So image you can see it is like a pretty transparent, it looks like a transparent. So just understand. I told you protein and pressure are increased in all meningitis, so that is not important to make a diagnosis, right? Some will have more protein, some will have less protein, but proteins are increased. Bacteria love glucose. Bacteria love glucose. So normal glucose, there's also MCQ came once in exam. So remember, normal glucose is 2/3 of blood glucose. Normal CSF glucose. If I say normal CSF glucose is 2/3 of blood glucose, so it will be like, suppose a normal people, what they have blood glucose like in the range of 100 to 120. So this will be 2/3 means it will be 66. If I say 2/3 of 100 will be 66.66. So understand this is 60 to 80%, right? 60 to 80 milligram per deciliter, or 2/3 means 66%. This is the normal glucose in CSF. Bacteria love glucose. So whenever you see this thing, CSF is decreased, it means it's a bacterial meningitis, right? So see, now chemical is ruled out, aseptic viral is ruled out. Viral is aseptic ruled out. Now we are left with tuberculosis, means TBM, tuberculosis and pyogenic. Whenever there is other bacteria, they will give certain color, right? Tuberculosis, either it will produce a normal color, or sometimes you will see straw color. We call this cobweb CSF. Cobweb CSF. So with this you can make a diagnosis. You can see protein is increased. This is your tubercular meningitis because color is almost transparent. That is what we call cobweb CSF. Okay, young patient with galactorrhea and amenorrhea. Remember two MCQs. Most common symptom of prolactinoma, galactorrhea. Second most common symptom will be amenorrhea, right? And most common pituitary tumors are your non-functional adenoma. Sometimes it can be functional. The most common functional type will be, so if I say most common pituitary tumor, the answer will be non-functional adenoma. Non-functional means they are not releasing any hormone. If I say most common functional tumor, then this will be prolactinoma. So in prolactinoma, what we give bromocriptine cabergoline, right? So the answer will be bromocriptine. So we prefer to give bromocriptine. Okay, now see this question: altered sensorium, irregular pulse, pulse deficit more than 20. So irregular pulse, these are seen. I told you this is seen in AF, atrial fibrillation. APD, pulse deficit means apex pulse deficit. So APD you can see in some ventricular ectopic beats, you can see in atrial fibrillation. I told you in the class itself, when you see apex pulse deficit is more than 10, then it is generally fibrillation. So again, APD, if it is more than 10, it is AF. Here in MCQ it is given 20, more than 20. So both things are satisfying. You made a diagnosis, so diagnosis will be your atrial fibrillation. What you will see in JVP, so remember there is no wave, absent. In AF you will see absent P wave in ECG, and there is no wave in JVP. So answer is absent A wave. Simple. Question is of atrial fibrillation. Okay, next I can say a known patient with diabetes, vomiting, abdominal pain, confusion, tachypnea, tachycardia, BP is low, blood glucose is very high, 538, current bodies are positive. So diagnosis you made, this is your DK. Diagnosis is diabetic ketoacidosis. So how you will treat this? First of all, what we need to give first should be your fluid. So first thing we will give IV fluid. IV fluid, then we give that insulin which is acting very fast. So we give regular insulin, or we give IV insulin. So IV insulin, what we have only one IV insulin, that is your regular insulin. So answer will be IV fluid and regular. Okay, only IV fluid. We give fluid initially, but you also have to control the sugar. Only regular insulin, no. First thing is fluid, then insulin. Both, yes, definitely. Long acting insulin, no. Long acting we give later on. Long acting like Detemer, Glargine, Digludec, these are given subcutaneously, not IV. You know, bioavailability of IV drug is 100%. So what we give regular insulin. Translocation seen in Burkitt lymphoma. So I can say, let me say 1517, this translocation, this is coding for RAR gene, retinoic acid receptor gene. And this RAR gene, I can say this RAR gene is responsible to cause M3 type of AML. M3 AML is also called as APML, acute promyelocytic leukemia. 814. So just I am writing this 8. Look at this 8 carefully. If you see B is the only alphabet, with B you can make 8, right? So see once again, this is your B. B is the only alphabet with which you can make 8. So 814 is for Burkitt lymphoma. 922 is your Philadelphia chromosome, that is for your CML. So this 922 translocation, that is BCR ABL gene fusion, you will get a protein 210. 1418, 14 F for 14, F for follicular cell lymphoma. Follicular cell lymphoma. So now answer will be your simple Burkitt lymphoma 840. So these are some important translocations that they can ask you. A female brought to emergency with history of having consumed 20 tablet of PCM. What drug you will give? The answer is N-acetylcysteine. Simple question. So that is they're asking you antidote of PCM. So we call this NAC. NAC means N-acetylcysteine. It's having multiple uses. First is it is used in PCM toxicity. They have asked before, this is a mucolytic drug. Mucolytic drug means, so sometimes you will see we have also given this drug in COVID patient because sometimes there is mucus plugging in COVID patient. Because of this mucolytic action, we can use this in cystic fibrosis. Okay, anyone can tell me other drug that we use in cystic fibrosis is your evac after. Evac after also we use nowadays. What else? What else we can use? What else section of anesthetic understand? Suppose there is a patient who is having a deranged kidney function, urea creatinine is high, and you want to do a contrast imaging, right? So first of all, what we do is avoid giving contrast to those patients who are having deranged KFT. यूरिया क्रिएटिनिन अगर बढ़ा हुआ है तो आपको कंट्रास्ट नहीं देना है. सपोज यू कैन नॉट मेक अ डायग्नोसिस ऑफ अ डिसीज विदाउट कंट्रास्ट. अब कंट्रास्ट देना ही पड़ गया तभी डायग्नोस बनेगा. सो कंट्रास्ट से पहले क्या करते हैं, पेशेंट को आप हाइड्रेट करोगे, प्रॉपर आईवी फ्लूइड. अगर मुंह से ले रहा है और टेल द पेशेंट टू ड्रिंक प्लेंटी ऑफ वाटर. प्रॉपर हाइड्रेशन इज मस्ट. And what we can use, we can also give an injection of N-acetylcysteine. So remember, N-acetylcysteine will also prevent contrast-induced nephropathy. Contrast-induced nephropathy, right? So this also MCQ came in exam. So you can see N-acetylcysteine. Okay, 4-year-old boy, frequent falls when he tried to run. Just by seeing the term frequent falls, don't make the answer Parkinson. It's the kid, right? It is not PSP or Parkinson. He's also having difficulty to getting up from a squatting position. Now you are getting close to diagnosis. Yes, you are thinking it is called Gower sign. Muscle biopsy is given. Which of the following is true about? So Gower sign is positive. So this is because you can see the sign in two conditions. One is called your Duchenne muscular dystrophy (DMD), and second is your Baker's muscular dystrophy (BMD). So both are more or less same disease. I can say Baker is a benign variant of Duchenne. So Duchenne, they will have death by 10 years of age, and Baker, they die by 30 years of age, 25-30 years. So understand this, both are having defect in dystrophin. So D4 Duchenne don't make dystrophin. So don't make dystrophin. There is no dystrophin. And B4 Baker, B4 bad quality. देखो दो लोग हैं, एक के पास डिस्ट्रोफिन नहीं है, दूसरे के पास है बट बैड क्वालिटी है. Always remember, something is better than nothing. Am I right? So bad quality dystrophin, no dystrophin. So Baker is considered a milder variant of disease, right? And you can see the question, boy is written. Boy means it's an X-linked recessive disorder. So this is commonly seen in boys. So understand, I told you like both these patients, they will have wheelchair bound. So they will have a muscle fatigue, muscle problems. They keep on crawling. There will be hypertrophy of calf muscle. They cannot properly stand. So what they develop hypertrophy of calf muscle. So these patients will be wheelchair bound. Your diaphragm is a muscle. So there will be diaphragm involvement and they will die because of diaphragmatic failure. So it is mitochondrial? No. Mitochondrial diseases are your MELAS. Mitochondrial encephalopathy, lactic acidosis, stroke, LH1, labor, hereditary optic neuropathy. Then we have diabetes and deafness, juvenile myoclonic epilepsy, NARP, neuritis ataxia, retinitis pigmentosa. These are your mitochondrial disorder. It is post-viral? No. It is a genetic disease, right? It's not post-viral. Death occur by 20 years? Maybe. It could be Baker's. Excellent prognosis? No. It's always having a poor prognosis. So answer is death by 20 years. By 20 or 30 decades, they die. So it means they are asking about Baker's. Duchenne, they will die early. Clear? Obese is having skin lesion. She is suffering from which of the following conditions? So you can see this is obese patient and you can see this lesion. We call this acanthosis nigricans. Acanthosis nigricans, understand, this is like blackening of skin. This skin blackening you can see in many conditions. So I can say the most common cause for this condition is obesity, followed by diabetes. Right. So you can also see this in lipodystrophy patient. So obesity, diabetes, these are two common reason. Then it's also seen in it's also a feature of visceral malignancies, especially your GI tract malignancy. Sometimes this becomes severe. When it becomes severe, we call this there will be a seborrheic keratosis. We call this lesser Trellat sign. Lesser Trellat sign. So understand this. Addition, hypothyroid, hyperthyroidism. Hyperthyroid will have weight loss, so it's metabolic syndrome. Remember metabolic syndrome, you will see features. This metabolic syndrome, the feature you can remember by mnemonic DOL. DOL means patient will be either diabetic or pre-diabetic. Patient will be either hypertensive or pre-hypertensive. O for obesity. There will be increase in abdominal girth. L for lipid. L for lipid. Now which lipid? First lipid is your triglyceride, that is high. Second lipid is your HDL. HDL is good cholesterol, so this is low. So these are feature, remember DOL. If 3 or more are present, then we make a diagnosis. So obesity is a feature of metabolic syndrome, and they are asking you, where you will see the most common cause of acanthosis nigricans is obesity. Simple. Okay, then you can see this is like a purpling of nail. You can see purple, or I can say violet discoloration or bluishness of your foot, or I can say toe. So this is due to warfarin. Right? Like, okay, so I can say like heparin, warfarin. These are like oral. These are old or conventional anticoagulants. So I can say heparin and warfarin. These are old anticoagulant. Heparin, we have different form of heparin, like we have unfractionated heparin, we have low molecular weight heparin, right? These are different forms of heparin. But nowadays what we have no newer, or I can say novel oral anticoagulant. We call them NOAC. These are your newer oral anticoagulant. So the point with heparin and warfarin is, whenever you are giving heparin, there can be toxicity of this, so you need to monitor this by PTT. For warfarin, you need to monitor this by PT or INR. So monitoring is needed. That's why we always deliver heparin or warfarin in the hospitals under supervision of physician. Which physician? MCI pass physician. Then what we give? We give newer oral anticoagulants. Newer anticoagulants, they don't need monitoring. So we have drugs like dabigatran. So this there is no monitoring needed, so patient can take this at home. We have dabigatran, we have rivaroxaban. We can have apixaban. There will be edoxaban. So understand this: dabigatran, rivaroxaban, apixaban, edoxaban. This Zaban, or I can say, you can see Zaban is having 10A, 10A, 10A. XA means 10A. So these are factor 10A inhibitor. So these are your 10A inhibitors, right? These are 10A inhibitors, and your dabigatran is your direct thrombin inhibitor. D for direct, D for dabigatran. And here you can see the name itself is having 10A. इसके नाम में 10A नहीं है. There is no 10A in the name. So these are your newer or novel anticoagulants. Okay, coming to the last question, cystocytes. Cystocytes, understand, cystocytes are your broken fragment of RBC. These are your broken RBCs, and broken RBCs, understand, this is your blood vessel. Whenever your RBCs, they move across a hard or sharp object, whenever RBC strike this hard or sharp object, what will happen? This RBC will break into pieces. You can see RBC will break into pieces like this. This is like your amino acid chain, so this will disappear. Only these changes will be left. So you can see this will look like an open face helmet that bullet bikers use. Open face helmet, right? So this is what we call this helmet cell. So broken RBC, or I can say helmet cell, or what we call them cystocyte. Broken RBCs or helmet cells or cystocytes. So these are seen whenever RBCs. So basically this type of anemia, what we call this MAHA. microangiopathic hemolytic anemia, and MAHA is seen in hypercoagulable state whenever there is a thrombi in the RBC tract, or it could be a calcified lesion, or it could be a mechanical valve, right? So these are not the cause of cystocytes. So whenever you see mechanical wall, artificial wall, any metallic implant, hypercoagulable state like ITP, TTP, HUS, DIC, they all can cause production of your cystocytes or helmet cells. So this is from my side some important topics which are coming in your exam in this year NEET PG exam. And remember, all these are easy questions. Just one thing you should do: don't be in a hurry when you solve from medicine question, because it need patience. It's not like a one-liner question you will get, but remember, everything is there in your notes. Just go with the concept. So with this, we will conclude this section. Hope to see you in some other videos with some more knowledge. Just a few days are left. Keep studying hard. You can. This is your time. All the best. Bye bye.